mute all and Fawad. Assalamu alaikum. My name is Dr. Khalid Mehmet. I'm a pulmonary critical care and sleep specialist here in Hagerstown, Maryland. Welcome to Apna Merit COVID-19 webinar. We are doing this webinar on a daily basis since the start of this pandemic, and we are learning from our colleagues, our expert, and we have participation, mashallah, from US, UK, Canada, and a lot of our attendees and expert panelists are from Pakistan, and we are all learning from their experience. To continue this journey, we have very experienced speaker, Dr. Fawad Chaudry, who is an interventional pulmonologist, critical care specialist, sleep specialist, and he's been part of this group from the very beginning. And he has taken, hosted the webinar and presented in the webinar. So without further ado, I will invite Dr. Fawad Chaudry to please introduce himself and start the program. Thank you.
Thank you, Dr. Kaleem. Appreciate it. So as Dr. Kaleem mentioned, I'm interventional pulmonologist and intensivist and currently serve as assistant professor at University of Oklahoma. I actually did the similar topic like 10, 12 days ago. So what I did today, I basically from that time till now, because this is ever-changing guidelines and new data coming, so I kind of tried to focus more. We'll go through the whole presentation, how the COVID-19 presents, how we diagnose and everything else. But main focus at the end will be what is the current situation with the therapy and medication. So I'll start and hopefully I'll finish in 25 minutes or less, and then we'll take questions. So again, objectives, we're gonna definitely do the literature review. I'm gonna go through some of the commonly asked questions, treatment guidelines, which are so many right now, so many societies have come up with their guidelines. The most recent is NIH. And then institution specific protocol, which I leave at the end. My presentation will be there. If any institution wants to, do the same guidelines, they're more than welcome to. And then how we can apply that in Pakistan. So I'm gonna skip through the initial portion very quick. All the references are there. We know that SARS-CoV-2 is a single-stranded RNA spread to humans from sources which are zoonotic source, likely bats. Person to person via respiratory droplet nuclei was the route of transmission. There have been described other routes as well for virus shedding, especially feces, but we don't know if that is the case for spread as well. Incubation is 3 to 12 days, and virus does bind to ACE2 receptors. But as of now, we do not know if we need to do anything with that. Currently, with the current guidelines, we do not stop the ACE inhibitors if the patient is on it, unless blood pressure issues are there. Let's see, somehow my slides are not moving. Sorry, the technical error, I guess. Okay, so basically, two important points here on this from this paper: 3 to 14 days of incubation period, and viral shedding is about 20 days. I'm not going to go into attack rate and the rest. It's been like 20 days from this paper. Most common signs, as we all know now, is 50 symptoms. It's 50 to 80% did present with cough, 85% with fever, and fatigue 69 to 70%. So this is a very good article to be read based on what symptoms they can present. Definitely, a lot of people are also presenting with GI symptoms as well. Lab, we all know lymphopenia and leukopenia quite common, about 80% of the patients. Many are presenting with elevated LFTs, AST, ALT, as well as the inflammatory markers like C-reactive protein and ferritin, etc., including D dimers, LDH, and interleukin-6. And these markers are the markers that you do follow, especially by day 8 or 10 when they really spike if the patient is going into cytokine storm that we'll talk. Imaging wise, it could be normal. So that's very important to know initially. Do not be fooled by a normal chest x-ray or a CT scan. Most of the times, if you are able to get the CT scan in the ER, ground glass opacities will be seen if the patient has some hypoxemia. Most of the times when they are positive and the CT scan is not done, we are not doing the scan. We are staying with the chest x-ray, or in centers who have expertise with POCUS, which is point of care ultrasound, kind of relying between the x-ray and ultrasound to detect, the ARDS as well as the infiltrate on the chest. Diagnostic testing wise, of course, send the nasopharyngeal swab for SARS-CoV-2, which is a PCR test. Co-infection has been seen, so important to send biopanel or PCR20. Do not order sputum induction and do not do bronchoscope just for diagnostic purposes. That has been well shown, and all the guidelines, including interventional society guidelines, they are not recommended because of aerosolization. Similarly, PFEs and spirometry for diagnostic purposes or for any purposes is not suggested and recommended against during the pandemic. Okay. Now, I'm just going to touch base quickly about what procedures, interventional and pulmonary procedures that can be performed, which may ease up in the next couple of weeks in US as well. Emergent bronchoscopy is if they have severe tracheal stenosis or bronchial stenosis, they have central airway obstruction or massive hemoptysis, or if the airway stent has migrated. Those are the few situations where we have actually done these indications, rigid bronchs and others. Other than that, most of the procedures have been on hold, which we are, the only exception to that is the lung masses where EBUS or diagnostic modality might change the management of the patient. We are still doing that. Most of the other elective procedures are recommended not to be done. Okay. Now, infection control wise, once all suspected patients, once the disease is diagnosed or suspected, droplet mask precautions should be done. If cohorting is necessary with a limited space, then at least 2 meters apart the bed should be. Visitors are restricted in all the hospitals, and that's what we recommend. Hand hygiene, we all know it's important. And what is the PPE that is recommended at this point? We're going to do standard precautions, contact precautions, droplet precautions with eye protection. These are must, right? Now, if there is an aerosolization procedure like intubation, extubation, if there is any reason for opening the vent circuit, any reason for bronchoscopy or nebulizer treatments, in those cases, definitely N95 or airborne. And the reason is we know that viruses are usually droplet precautions. This virus is so small that there are chances that it can suspend in the air for a couple of hours or 3 hours. Okay. If available, consider PAPRs, which is powered air purifying respirators for procedures, okay, and or intubation as well. Now I'm gonna jump to the treatment. How do we treat it? Let me see. Everybody can hear me okay?
Yes, you're doing okay.
Okay, very good. So now I'm gonna jump to treatment modalities. Basically, ARDS management once they're in hypoxemic respiratory failure. Okay. Avoid NEBs, as I mentioned. Empirical antibiotics only if secondary infection is suspected. Non-steroidals, avoid if possible, according to WHO guidelines. ACE inhibitors and ARBs continue per ACC and AHA guidelines if the patient is already on, unless there is hypotension or other reasons to stop. Again, look closely for cardiomyopathy, cardiogenic shock, and arrhythmias and other cardiac complications. There's a very good study that came out in JAMA that showed 33% of patients with some cardiac issues. DVT prophylaxis on all, at least prophylaxis. We'll talk a little bit more later. Many institutions are doing therapeutic because these patients have approximately 30% risk of clots, PEs. Corticosteroids wise, WHO, CDC, and now, as of yesterday, NIH guidelines are also out. They're recommending against, unless it's refractory shock. SCCM are recommending for in severe ARDS, which is when they are in cytokine storm, which is a weak recommendation, but certain institutions are doing it. Okay. All right. How do we go about with hypoxemic failure? Very important to know that this is ARDS. This is ARDS. Dr. Kalim and I were talking before as well, before the start. There have been so much going on social media. This is ARDS. There are different categories or different stages of ARDS, and that kind of is pretty much what we have seen. They do go into rapid hypoxemia, but they act like ARDS or rapidly progressing ARDS. So early intubation is by all societies. Before that, nasal cannula can be used or high flow. Now, SCCM as well as NIH has recommended you can use NIV for 1 to 2 hours or non-invasive ventilation if it helps, but do not linger on for 24 hours or so. Just make a decision in a few hours if the patient has to transfer high flow to NIV to intubation, but consider early intubation. And when you are intubating early, use the rapid sequence intubation, which is with paralysis, so they do not aerosolize a lot of virus particles for the person who's intubating. Use video laryngoscopy if possible. So it's it's a bit far from the patient, and it's one attempt in general. Again, people who are expert with direct, they can do it, but that's much more closer to the patient's mouth. So recommendation is try to use video if available. For ARDS management, just do a good ARDS management, which includes low tidal volume ventilation, PEEP protocol per ARDS net, prone positioning. You can use INO if the above 3, which I mentioned, are not working. So just do a good ARDS management, and these patients should get better, especially with early intubation, low tidal volume, good PEEP strategy, and proning, with or without INO. Okay. ECMO is only for refractory, and that's the percentage of ECMO has been very low in general, anywhere from 1% to 17% in various studies, but that can be tried for refractory ARDS. This is a slide that I put it on purpose because so much had been going on about hypoxemia, the routes. This paper just discusses the two various kinds of phenotypes in ARDS in COVID-19. One phenotype in which lung compliance is good and you use low PEEP strategy, and the L phenotype in which the lung compliance is much worse and you use high PEEP strategy. Number one, this is ARDS. Number two, these two phenotypes are pretty much what we see in various stages of ARDS. So I would stick for, unless we have some more evidence base, that this is ARDS and there is early and late phase or early and intermediate phase. Okay. And then there is some good commentary down there in the link that can be read. That's why I put everything on one slide. Now I'm going to focus a little bit more about the specific therapies, and I think we still have like 10 minutes. So lot has to be known and lot has been done in the last 1 month. Okay. So from the last time I gave the presentation till now, there have been some more papers that I'm going to discuss. Bottom line, there is no proven therapy at this point. Okay, FDA-approved drugs like chloroquine and hydroxychloroquine for other indications, they can be used as an off-label. What does chloroquine and hydroxychloroquine do? They block viral entry into the endosome, basically block the entry of the virus into the cell. In vitro data does suggest there is some utility, but data from RCT is of course lacking. Now, some investigational use that is available in US that includes remdesivir, which is antivirus nucleotide. This is available at this point as part of trial. Lopinavir and ritonavir, we all know that a couple of studies came back negative and recent negative RCT, so most institutions are not using it at this point. Tocilizumab, which is IL-6 inhibitor and is used in cytokine storm, has had some data, and some institutions are using with good results. Similarly, convalescent plasma, which is an ancient therapy, is also being used with some good results. Let's discuss these. Now, I'm going to start with convalescent plasma. Now, this is an old concept that has been going on since influenza pandemic in 1918, and it was used then. It was used in influenza pandemic in 2009 and 10, as well as during SARS pandemic and MERS as well, with some good results in general. Okay. Now, experience with SARS, there was one study that it's not very clear, but I put a reference, about 80 patient case series. There was improvement in mortality and shorter hospitalization, but most outcomes were better when the plasma was given within 14 days of onset of symptoms for that study. Okay, but there are some inherent difficulties with convalescent plasma. Some of the donors may not produce adequate titers, and some may not have neutralizing antibodies. And there are, of course, several other matching, compatibility issues as well. So it's not without issues, but in most studies that has worked, not only in the other pandemics, but also in COVID-19 that I'll share later. Now, what is the evidence of COVID-19 of convalescent plasma in COVID-19? So this is a study that was published in March 23rd, and a total of 10 patients. All had received concomitant therapy prior. Now, the results-wise, following the CP transfusion, all patients had negative PCR via nasopharyngeal swab. 3 out of 10 patients were intubated prior, and 2 out of 3. So 3 intubated, 2 out of 3 were extubated within 3 days. And that cohort of 10 patients were compared with another 10 patients who were from different hospitals, not from the same hospital. So that kind of puts a little bit of sampling. But again, I think that's the best they could come. Safety and secondary endpoints of clinical and lab parameters were actually met with this study. Then we have another study published, this is out of China as well, of 5 critically ill patients. All of them were intubated and they received convalescent plasma. It's a busy slide, but the gist of it was out of all those 5 patients, all of these patients recovered from their fever. 4 out of 5 got extubated. 3 out of 5 were discharged, and 2 out of 5 basically were in stable conditions after 30 plus days. So in general, a positive study with no mortality, which is decent. Very small study, but no mortality. We know that mortality has gone up to 50% in China on the ventilator patients, and up to 60 plus in Italy, and quite a bit in US as well initially. Now, so these are the only 2 studies in the convalescent plasma in the COVID-19 as of yet, as of my knowledge. Okay. Now we go to chloroquine and hydroxychloroquine, for which, of course, that has been most talked about in the media and everywhere else. So again, that's an old medication that has been used in anti-malarial since 1934. Now later discovered that SLE, rheumatoid arthritis, the role of hydroxychloroquine is there. Now in early 2000s, it was noted to have antiviral activity. And as I mentioned, it interacts with endosome-mediated viral entry into the cells by increasing the pH of lysosome, and basically also impairs viral replication. There is a paper published in Lancet 2003 that kind of goes over well in detail of the mechanism. What is the evidence behind this medication for COVID-19? So there are three in vitro studies demonstrating hydroxychloroquine can inhibit SARS-CoV-2, and hydroxychloroquine is more potent than chloroquine. The references are down there. Okay, so again, that's in vitro. What about azithromycin? We all know that it has anti-inflammatory effect. We use it for COPD. It has antiviral activity that was proven in vitro during SARS, Zika, RSV, and influenza pandemics. Okay. As of yet, we do not know that it has any in vitro activity against SARS-CoV-2. So it has been tested for in vitro in other viral, SARS, Zika, and RSV, as well as influenza, but not in SARS-CoV-2. Okay, so that's important to remember. Now, about the clinical study data combining hydroxychloroquine plus azithromycin in humans, not in vitro. So with 3 in vitro are showing that inhibits virus. So I think the most media attention was after the French trial. This was one published in March 20th, open label, non-randomized in France. 14 patients were treated with hydroxychloroquine. Dose was, as we know, 200 milligrams TID for 10 days. 6 patients with hydroxychloroquine plus azithromycin. And there was a 16-patient control group from other centers. Okay. Day 6, there was a negative PCR in nasopharyngeal swab, I believe, in all the patients. Okay. 8 out of 14 in hydroxychloroquine, 6 out of 6, sorry. So the negative was 8 out of 14 in hydroxychloroquine, 6 out of 6 in a combination group, and 2 out of 16 in the control group. So overall, much higher negativity in the combination group regarding PCR. One of the patients did convert back to positive PCR on day 8. And we have seen it lately, all of us who have done this, that some of the patients are converting positive at day 20, 23, 27. That doesn't mean that they have active virus, could be just that they're infected. It just could be a dead nucleotide or particle, virus particle, as opposed to active virus. Anyways, based on this study, we know that there is no, that virus COVID has been converted negative with regard to the nasopharyngeal detection. But these studies have not given very good evidence how the patients do clinically. There was 1 death, 3 ICU transfers, 2 dropped out in the current study. And information on disease progression, clinical outcome was not presented. So primarily the purpose on the study, the reference is decrease the viral load and assuming that indirectly it will help with clinical manifestation. The second study, March 27, 2020, that got published, open label observational study, again, France. 80 patients treated with hydroxychloroquine and azithro, no control group. So, and again, favorable outcome was 81.3% on day 5. Viral cultures were negative in 97% plus patients, and day 8, PCR was negative in 93% of tested. But the caveat in this study was 92% of population was considered to have mild disease. So they were not the ICU patients. Only 15% of these patients had fever. Only 15% required oxygen, and actually 4 patients were asymptomatic. So it was a milder group. They could have been better without any intervention, like in terms of the commentary on this study. Anyways, that's what we have. So what do we have so far regarding that hydroxychloroquine and azithro? So 2 studies in China and France showed no benefit. 3 studies did show benefit of viral load reduction, with of course various methodological errors in these studies. So that's all we have about this. How much it benefits clinically, we don't know. Okay, there was one study that was in the pre-published phase that basically NEGM. I'm not sure if it's published finally or not, but that showed about out of 63 patients, 32 in the hydroxychloroquine arm and around 30 patients placebo or no hydroxychloroquine, and there was no difference. In fact, those that were on hydroxychloroquine had more intubation because probably they were sicker. But I have not gone into details of that study, whether it's published or not. But the definite published ones, we just have evidence of viral clearance, not much clinical data, the clinical improvement data at this point. Changing gears to remdesivir, which is an antiviral nucleoside. So that's the only published study on remdesivir on COVID-19. They basically compassionate use trial of 53 patients in multiple countries, 9 countries. Dose was 200 milligram daily for 10 days. Population-wise, median age was 64. 57% of patients were on ventilator. 13% of the patients were on NIV or high flow. So typical group of patients. Overall improvement in oxygenation was pretty good. All 12 on room air improved. 5 out of 7 on NIV improved, 71%. 17 out of 30 on mechanical ventilator got extubated, which is 56%, and 3 out of 4 on ECMO also improved, which is 75%. Mortality-wise, total 13% patient died, which is again much less than what we used to see. On the ventilator, only 18% or 6 out of 34 patients died. And on NIV, 1 out of 19, which is 5% patient died. So again, this mortality is much more livable for ARDS as opposed to 50%. So again, it's not a perfect study, but it is what we have for remdesivir and shows that may have some benefit. Okay. What about tocilizumab? So this is the study that I'm gonna just kind of make it easier to put it out there. It's a humanized monoclonal antibody against IL-6 receptor. Tocilizumab is an anti-IL-6 in simple words. It's approved by FDA in 2017 for severe life-threatening cytokine release syndrome. So in the above study, what they found out in China, it's a retrospective study, 21 patient study, 9 patients had hypertension, 5 had diabetes, all 21 were critically ill. 2 were on the ventilator, 1 was on NIV, and 9 were on hypooxygen. And all patients had received 1 week of antiviral plus steroids before tocilizumab, and they did have clinical deterioration before receiving tocilizumab. Results-wise, all 3 patients on the ventilator were extubated within days of tocilizumab given, and followed the cytokine release or STORM guidelines in terms of what are the numbers of inflammatory markers and all that. After treatment, CT chest improved in 90% of the patients. Very good response. No control arm in this study, of course. Expected mortality based on the sickness of the patient was at least 20%. However, 0 deaths in this group with tocilizumab, which is pretty decent. Again, we do not have a control arm, but what we have in all these studies, this seems to be pretty decent response in patients going on cytokine relief. And I would just move on to say that we have used tocilizumab in our center and 0 mortality in our center as well. So it has, if used properly, it is working and it is helping. And currently there are 10 active clinical trials on tocilizumab in COVID-19. So this is, I think, the summary that I wanted to give and take away for the audience for this lecture/presentation. Tocilizumab, we have 1 study with promising results. There are several case reports and several trials going on. Use it if you have cytokine release syndrome, and use it if available. Going to convalescent plasma, there are 2 very small publications with hope. It's an ancient method, but we know that against many viruses it does work. So there are 2 small publications that I discussed with some positive results. Remdesivir, promising in vitro benefits against virus. There is only 1 study that we just discussed, and a compassionate use, above 50 patients. A lot of study limitations, but some decent outcomes. Hydroxychloroquine and azithromycin, again, promising in vitro data. 5 studies that we discussed with conflicting data with methodological flaws. So out of the whole, I think what we take, the top 3 are more, I would say, reasonable. But again, hydroxychloroquine and azithromycin, until we have other studies come out with some randomized trials, it's okay to try in those patients who are hypoglycemic. Few other slides I'm going to finish in a couple minutes. This paper, good read. Read it. About 30% chance of thromboembolic events in patients with COVID-19. However, International Society of Thrombosis and Heme has recommended to have a prophylaxis. They are not recommending as jet full dose anticoagulation. It's institution specific. Many centers are doing it. And you should have a low threshold for anticoagulation, especially in patients, full dose anticoagulation, especially if they are not improving hypoxemia despite doing all the measures. Prognosis wise, I'm gonna skip it. Just say 80% of patients have mild symptoms. This is the largest study that came out of China. 15% moderate, 5% will require mechanical ventilator. We know that patients older age with comorbidities do poorly. SCCM recommendations I pasted here, but they are pretty much the same as NIH recommendations and other recommendations, and they talk about the same manifestations. I want to repeat one more time. For ARDS management, the bottom line of all these recommendations from SCCM as well is early intubation, early proning. We know that proning does improve mortality from prior studies in ARDS. Here, it is helping definitely big time. If early, despite the low tidal volume ventilation, 6 to 8 ml per kg, and prone ventilation, patient is still not getting better, and that is again early proning, consider INO. And I forgot to mention, with proning, most of us do use neuromuscular blockage. That doesn't improve mortality, but has been shown to improve oxygenation. So early intubation, ARDS net protocol guided, deep strategy with low tidal ventilation, early proning, neuromuscular blockage. Okay, if these 4 modalities are not working, then consider INO or prostacyclin for vasodilatory response. If despite all that, patients are deteriorating ventilator-wise, then consider ECMO. This is just medication aspect is all different that we already discussed. Okay. This is our protocol. I'm not going to go into detail because we're running out of time, but it's there. It's all that I've discussed. One thing I want to let you know is we are very aggressive in doing the testing and inflammatory markers that include D-dimer, CRP, ferritin, LDH, because when they go high, ferritin about 1,000, CRP above 20, high LDH close to 1,000, as well as D-dimer about 1,000, they are getting into cytokine storm. That is important. You do it every other day. These parameters are every day. And if they are, then consider medications including tocilizumab, and with asterixis, possible steroids if tocilizumab is not available. IL-6 is available, very important to do it, but most centers don't have it. The level is around 400. If that is that level, then consider using these medications. So that's all the protocol. I'm not gonna go into further details of that. One thing, I just put some slides for steroid has been the work of steroids, the steroid and virus has a controversial relationship. There's a lot of references, I put it there. Most centers are not using it because we have WHO, CDC, and now NIH are recommending against, unless you have hypotension or other reasons to use. SCCM has recommended for in severe ARDS. Their reasoning is all here because it has worked in some of the previous big trials. And Memorial Sloan Kettering Cancer Center, which was my parent institution as well, they've used and they've been using it. I'm waiting for their paper to come out. Dosage of steroids is there. So what I would say about steroids, and full disclosure, in our institution, we are not using it for severe ARDS, but we have tocilizumab and other medications, okay? If in Pakistan, you do not have in a certain hospital, patient is going into storm, read through the SCCM guidelines and read through these criteria, which is set up by Sloan Kettering. That's how they're using. So it's okay to use in those situations. If you have tocilizumab and convalescent plasma, at this point, we have more data for them. Okay, so I will leave there for questions. Thank you.
Thank you, Fawad, for this excellent overview of COVID-19 and its related thing. You cover almost every aspect of this disease process. As we've been discussing our webinar, we have a very large group of attendees and panelists, and again, all the attendees and panelists, thank you very much for joining. And this is your forum, and you all are very, very important for educational purposes. We learn from each other, and it is a learning curve. Before I proceed further and start the question and answer, I would request all of you to please write your question and answer to the question and answer box, and I'm going to try to get as many as possible. Also, we have some questions from the Facebook, and I'm going to take one by one. So Please, I'm going to ask my panelists to please introduce yourself, starting from Dr. Shahid Rafiq.
Assalamu alaikum, Shahid Rafiq. I'm a neurologist, vascular neurologist and sleep specialist here in Frederick, Maryland, near Washington, D.C. I'm also a Merit Chair. My job here is mostly coordinating. And thank you for all to attend.
Next, Dr. Bushra Ali.
Okay, I'm Bushra Jamil. I'm a professor of internal medicine and infectious diseases at the Aga Khan University, and I'm also the president of Medical Microbiology and Infectious Diseases Society of Pakistan.
Bushra. Professor Shamsa Himayu.
Assalamu alaikum. I'm Dr. Shamsa Humayun, professor and head of Gynae Department, Fatma Medical University, and I'm Vice President, Society of Obstetricians and Gynecologists of Pakistan as well.
Thank you. Dr. Mariam Morton.
Assalamu alaikum. I'm Mariam Morton. I'm a staff cardiologist at the VA and I'm professor of medicine both at UCR and Loma Linda University. I'm a non-invasive cardiologist and I'm also the president-elect of APCNA.
Dr. Nighat Ahmed. Dr. Nighat.
Professor Nighat Mir Ahmed. I am professor of rheumatology and chair of faculty of rheumatology at College of Physicians and Surgeons, Pakistan.
Thank you, Dr. Nighat. Dr. Nuzhat Ashi. Dr. Nuzhat. You can unmute the microphone. Okay. I think.
Can you hear?
Yeah, go ahead.
Dr. Nuzhat Ashai. I'm a staff nephrologist at Cleveland Clinic in Cleveland, Ohio, and medical director of a dialysis unit in West Side.
Thank you, Dr. Nuzhat. So I have a couple of questions already here, and I will ask our panelists to please chime in as you wish. So there is a question asked about the importance of N95 mask with the exhalation valve. So as we know, there are different type of N95 available, and a lot of our healthcare providers are a little confused about this different type of mask, different shape. So Fawad, do you have any comment on that?
So basically, N95, first of all, it's 95% effective. The 100% effective is pepper. With exhalation port, I personally don't know if there is any benefit, but maybe somebody else from ID or Kalima, you know about that.
Anybody else has any opinion about? So what I have been told by my ID experts here that sometimes people who are using the exhalation port, it's easy for them to breathe out, and it's not as restrictive in your breathing. Otherwise, as far as the effectiveness of the filters are concerned, there is no significant difference between regular N95 and N95 with exhalation port.
So, Dr. Karim, do you know any place here in US that they are routinely using? I've just seen the two kinds of N95 that we usually have in US. Do you know any place that use the N95 with an exhalation port in US?
So in our institution, we were running short as all over the world. So we acquire at least 4 different types of N95. And one type of the N95 has this exhalation kind of thing. And they also, they're like some people are having problem with the fitting because of the nose bridge and the shape of their cheek. So if M3 is not fitting, there is 2 other different type of supplier, and they some has some lining into it. So, you know, and then there is some, not here, but I have seen people in other areas, they are using this K95, and I think in the Pakistan also, this Chinese brand they are using. Our Pakistani colleague, Dr. Professor Shamsa, do you have any experience in that?
Sorry, I did not follow. दोबारा से.
वो क्वेश्चन वाज कि जो एक्सेलेशन पोर्ट के साथ N95 अवेलेबल है, कुछ तो उसकी कोई खास सिग्निफिकेंस है, और आप लोगों ने कोई ऐसी चीज देखी है वहां पर पाकिस्तान में? और K95 एक ब्रांड आता है चाइना का वहां पर.
हाँ जी, हमारे पास तो है KN95. N95 जो इनिशियल था वो तो बहुत कम लोगों को मिला, उसके बाद KN95 आज तो सप्लाई हो रहा है, और हम उसके साथ सर्जिकल मास्क भी डबल इट.
Dr. Bushra, I think you might shed some light on this issue of different type of N95.
इस वक्त तो ये है कि जो अवेलेबल है उसी को यूज किया जा रहा है, and this KN95 is the same, expected to be the same as N95. It's just manufactured in China. फिटिंग के साथ इश्यूज इनिशियली हुए हैं और फिट टेस्टिंग हो रही है हमारे यहाँ. दोनों रेगुलर N95 एंड KN95 दोनों के साथ फिट टेस्ट में प्रॉब्लम्स लोगों को आ रहे हैं. So what people are doing here, especially those who have a beard, they have gone for another kind of mask, which is a reusable plastic contraption, which is available online. So वो reusable mask सब काफी सारे लोगों ने procure कर लिए हैं, और उसके अंदर भी ये exhalation valve होता है, and the purpose of this valve is to reduce heat build up within the mask. So it is for the comfort of the wearer. So अवेलेबिलिटी का ज़्यादा है, जो से अवेलेबल हैं वही यूज़ किए जा रहे हैं. बहुत मर्तबा फिट टेस्टिंग या तो अवेलेबल नहीं है या पॉसिबल नहीं है. सो उस केस में हाई रिस्क एक्टिविटी वाले सारे जो फिजिशियंस हैं, स्पेशली ORs में जो काम कर रहे हैं, दे आर गोइंग फॉर दिस reusable plastic contraption, which is a big structure but can be reused and is effective.
Dr. Bushra, I think the plastic structure is this pepper, क्योंकि with beard.
नहीं, पेपर अलग है. जी जी, पेपर तो है. पेपर लिया है इंटेंसिविस्ट और एनेस्थेटिस्ट के लिए. दैट इज स्पेसिफिकली फॉर पीपल हु आर एंगेज्ड इन इंट्यूबेशन एंड वेंटिलेटरी केयर. पेपर वाला अलग है, लेकिन मास्क्स भी हैं. आई कैन शेयर द इंफॉर्मेशन विद यू ऑन ईमेल, जो यूज हो रहे हैं. काफी सारे लोगों ने खुद से प्रोक्योर करके अपने पर्सनल लिए, स्पेशली क्योंकि वो बियर्ड के साथ इशू हो रहा था.
Exactly, क्योंकि बियर्ड के साथ N95 100 फिट सही नहीं हो सकती है, जो
नहीं हो नहीं सकता.
our knowledge तो
हाँ, मैंने share that link
as close as possible. ठीक है.
Okay, so there is a couple of questions. I think I'm going to sum up with this. I think this is related to cytokine storm and other issue with the increased inflammatory markers in the COVID-19 severely ill patient. So the question is, Fawad, if you could explain about what is cytokine storm and in general, and related to that question, if you can also shed some light about somebody's asking the role of damping down inflammatory response strategy, like treating this increased cytokine storm condition as graft versus host disease response, and any studies or use of any mesenchymal cell transplantation in critically ill patient. Kind of a little loaded question, but anybody can chime in, but let's start with the Fawad.
Yeah, ठीक है. So I think it's a good question. So to make it simple, cytokine release syndrome is basically when the pro-inflammatory or our immunity fights with the virus, and then the cytokines are so much that they become the damaging factor. It's the same as in sepsis. There is such a complex array of anti-inflammatory and pro-inflammatory, and both of the pathways can damage. Okay, So here, our pro-inflammatory storm is so much that is the reason that we are going into ARDS with the leaky capillaries and release of sort of formation of hyaline membranes and all the inflammatory mediators releasing into the lungs and into other organs. So that is cytokine storm. And that has been seen with other medications, including CAR-T, which is in hematological malignancies. So how do you know it is? You basically have to follow those inflammatory markers that I mentioned. IL-6 itself is very specific. Not all institutions have it. Sometimes it takes days. But very high level of CRP, other inflammatory markers like ferritin and D-dimer, if they continue to rise, that tells you that our pro-inflammatory response of body is going unchecked. And at the same time, if clinically patients are going into ARDS and multi-organ failure, then this is cytokine storm. So now you know that if you don't check it, that's going to kill the patient as opposed to the virus itself. And to stop it, you have tocilizumab, which is anti-IL-6, and multiple studies prior has been done, and some, as I mentioned, in the COVID-19. So you use those anti-IL-6 markers, and some of the institutions, as I mentioned, steroids is more broad. They're using steroids to calm down that inflammatory storm, and they have some beneficial effects. The after effects can happen, and there is some thought that if we now we are suppressing the immunity per se of the body by these anti-IL-6 or steroids and other medications for cytokine storm. Superimposed bacterial fungal infections, TB, and other things can happen along the way in 2-3 weeks or earlier than that. So that's that. I did not catch the second question, or I don't know if I explained already, or.
So there was a specific question about treating as cytokine storm related situation as graft versus host disease and use of mesenchymal cell transplantation. I have not seen anybody, any studies. So if somebody has any experience in that, one of my panelists has any experience.
Yeah, maybe somebody. Yeah, I'm not aware of somebody using those in COVID-19.
Dr. Morton, have you seen anybody treating this as a graft versus host disease kind of phenomena and using this?
Not as of yet. You know, you never know what might come up in the future, but no, we haven't had any experience with it as of yet.
Yeah, and then as we have reviewed several guidelines, including the most recent NIH guideline, where all the different societies, including ATS, American College of Physicians, Department of Defense, Infectious Disease Society, you name it, and everybody, I have not seen reviewing of that, anybody is recommending those. So I have other few questions. I have seen multiple hand raised, and I'm going to come to you all one by one, but let me go through some questions. There is some, in fact, multiple questions. I'm going to lump some together about the use of different antiviral, anti-HIV medication, including lopinavir and ritonavir use. And also there is another, somebody was also asking about any use of ritonavir in COVID-19. Dr. Bushra?
What we have available here is obviously hydroxychloroquine, azithromycin, but tocilizumab is available at our center, and I'm aware of 2 other centers which are using tocilizumab. I don't know what is going on in the rest of the country because there is no platform where we can sit and discuss. This is a very important platform, I guess, because I get a chance to talk to all of you and get the information. So I can tell you about our experience with tocilizumab. We've had around 40 patients who have received it with very good results. We have been using hydroxychloroquine and azithromycin quite liberally, but I haven't had a chance to actually review how they have performed, because even the clinical services are fragmented, so there isn't a single team which is looking after these patients. So it is going to be difficult to retrieve all this information, but that is very important. Another drug which I think we are not paying enough attention to is ivermectin, which is cheap, has been available in Pakistan for a long time, and it has been shown to have antiviral activity against SARS, the old SARS, and MERS, and in vitro activity against SARS-CoV-2. So I think it is worth trying ivermectin in our patients because it's oral, it's available, it's cheap, and has very few side effects. I would like your opinion on that.
Thank you very much. I think one of the Dr. Shahid Gill also asked about this medication. So, what any?
Yes. So just a quick comment on the lopinavir is there has been a recent end of March RCT that showed no benefit of lopinavir, ritonavir. So regarding those antiretroviral, until further data is available, that has been going out of favor. Okay, so that's about ritonavir, lopinavir. Now regarding ivermectin, I have not seen any specific studies other than what Dr. Bushra mentioned. So I would say it's limited at this point, evidence to use it, but I will leave it to rest of the panel if they have more experience with that.
Dr. Nusrat, do you have any comment on this? Any opinion about ivermectin?
No, I do not, because here in the Cleveland Clinic, at least, among our staff meetings, I have not yet personally had the experience of treating any COVID-19. My call starts next week, so that is going to change. But we do have regular meetings about these patients, and that has actually never been mentioned as a choice, at least yet.
Yeah, thank you very much. Now, coming back to some other question, there is a, anybody making a comment on ritonavir, again, another antiviral. So I think we already answered this. So far, we don't have any data, some negative study about some antiviral, some ongoing studies going on. So we have to be just patient and see what would work.
Can I make a comment about other things that have been tried? There was just recently an article published in JAMA that was looking at a study that was done in China, and it was a retrospective multi-center trial. There were about more than 1,000 patients, and they were actually looking at, and this has got nothing to do with the antiretroviral or infectious disease, but this was more to do with the question about the ACE inhibitors and ARBs. And they did show in the study, even though it had its own limitations, that patients who with hypertension who were admitted with COVID-19 and were hospitalized with it, they had a lower risk of mortality when they were on the ACE inhibitors and or the ARBs. So
absolutely.
Thank you very much. Excellent effort. I've been attending, hearing some of the recordings, and for the last couple of days, I've been attending the morning webinars. So keep it up. Good work. Really good effort. I've got a question. As I'm a pulmonary and critical care physician in KP, and my understanding is that we need to avoid use of NIV in patients with COVID, right? However, you mentioned in your talk that you can use it as a kind of bridge to lead to intubation. Now, has that changed? Are we allowed to use it now? One. Second is, if you've got somebody who is not a candidate for intubation and ventilation because of other comorbidities, is it something which NIV you would use as a ceiling of treatment?
Thank you. Yes, go ahead.
So, no, you go ahead, Fawad.
Yeah, so very good question. regarding NIV, based on SCCM guidelines as well as NIH that came out yesterday, that's kind of in the gray area. So early intubation is still the key, and both these societies are suggesting if you feel that you may protect these patients from intubation, especially in those circumstances if you have 40 patients and 30, like I'm just giving you an arbitrary scenario, when you're overwhelmed. So I mean, in those situations, I would say you can try it for a couple of hours, but certainly for a short trial, that's the recommended if you need. But it's not recommended to use it for 24 hours like we do it, in a normal situation. So yes, in the guidelines, there is that thing that you can use if you want for a short trial. That's about that. You have something to say, Dr. Karim?
No, I think you already covered that. I think the only thing which I think there was a lot of confusion about whether this is a contraindication or not. A lot of people, because when they read the society guideline, it's basically suggesting or discouraging not to use it. I think there's two issues here. Number one is the prevention of the healthcare provider and aerosolization of the viruses. And one of the major reasons of avoiding anything, including the non-invasive ventilation, if you are using it in an environment where it is not fully protected for the healthcare providers, and we don't have a significant negative pressure room or other thing like that. As far as the bridges, we always use that thing. As far as, I think the question was about the ceiling. Well, it is depending upon the patient code status. If somebody is not supposed to be intubated, coded, and you are struggling, then in protected environment, trial of that is probably what we all do as a basic critical care management of these patients. Dr. Shamsa or Dr. Nigat or anybody else has any comment on that? Okay. So thank you, Dr. Asim. I have another attendee, Dr. Shazmi Khan. Please unmute yourself and introduce yourself and ask your question, please.
Very good conversation. I'm listening to all these sessions, and I really appreciate the efforts, put in there by everyone, starting from March 31. So just to put a certain, because I was quite pondering about the STROM, what is it? It's just like, if you look at the, it's a review article, I think. Meng Zhao, he has published this article on April 16th. So that's actually just like tornado. It was showing like how the cytokine storms. And specifically in this disease, you have the your granulocyte stimulating colony stimulating factor that is increased, and then you have other proteins which actually activate the monocytes, and they activate the secretion for IL-6 and other, which are part of the STROM, the cytokine storm. Now, when I looked at the somebody talked earlier in the session about the filgastrum. So when I looked at the side effects of the filgastrum, which is your colony stimulating, granulocyte colony stimulating factor used in leukemia and other places. So the side effects of those, that drug, exactly what we are looking at, the picture of the COVID-19, that there is a headache and there is increased, thrombosis and all that things, and I think that's that thrombosis, the thrombocytopenia leading to the because of the thrombosis, and then that's what I think that leads to disseminated intravascular coagulation. Now, putting the stuff straight, so your door to enter into your home is the ACE2 receptors. Now, these cytokines are kind of, your taps and your whatever in your home. So once this virus enters into the home, it opens all the doors, right? And it opens all the taps and cause the flood or whatever, storm or whatever. Now, from the pharmacological point of view, the more the number of ligands in there, there's a competition. So if we give something like AC inhibitors or something which actually are not inhibitor but an agonist at the ACE2, then probably that will compete with the virus and can inhibit the entry of the virus within the cell, pneumocyte 2. That is one. The other thing is that just like we go into the malaria endemic area, so we take the prophylactic drugs. So corticosteroids are not going to help in those patients. It's the same guy I was mentioning, 16th April review article. He has given a lot of references and researches from different portions of the world. So if we just give the look at the markers, not just the LDH and all these things, these are the side effects of the filgastrum. So are these because of the release of the granulocyte colony stimulating factor? So that means we basically need to measure the GCSF concentration, and if that is increased, then we have to do something to stop it. If we look at the IL-6, then yeah, we can start with the tocilizumab. And if we look at, the critical patients and severe adult acute respiratory distress syndrome, then we can give the steroids for 3 to 5 days course. That's what they recommend. And that decreased, there was 0% deaths in those cases where they use it in the critical and the severe cases for 3 days. But obviously, we don't want the patient to go into the severe states. We want to prevent it. Is there a way we can prevent it? So they are talking about the chloroquine and hydroxychloroquine. If it is a prophylactic, I think you can use it as a prophylactic. This is an educated guess. There is no baseline study for as far as I know. And that is why this is an educated guess, because if you look at the mechanism of action, they are postulating, they say that beside it has an anti-inflammatory effect. It has also inhibiting the MHC2, major histocompatibility complex 2. It inhibits that, and that's how it prevents the binding and the activation of the T lymphocytes. So, preventing the lung injury.
So yeah, we got the idea. There's a lot of hypotheses and a lot of pathophysiology, and but the issue is that one could speculate things as far as the use and outcome, management of disease process depending upon the outcome. And most of the time we rely on the outcome on the basis of randomized controlled trial. We don't have the luxury of that. We have case reports coming up from different journals. And as you mentioned already, my current reading of the NIH guideline about the prophylaxis of use of any medication, considering all the hypotheses, they are not recommending anything for even before exposure, during exposure, and after exposure. If anybody else in the panelists has any comment, Dr. Moten or Fawad, please chime in.
Yeah, I totally agree. I think these, Dr. Shazmi, you describe all the pathophysiology or mechanism good, but we don't have evidence at this point to use prophylaxis, number one. Number two, these medications are going off the shelves. I mean, the patients really need it. We can we can make a hypothesis that it may work prophylactically, but there's no evidence at this point. None of the societies have recommended to use it. And even for treatment, we don't have much evidence as they presented those 5 studies. So it would be hard to say to use prophylaxis at this point.
Dr. Moten?
Yes, that's a good hypothesis that you're bringing up forward, and bringing up questions like this will help us understand the disease condition and the pathophysiology behind it.
Okay, very good. Dr. Nighat, any comment?
NIH released the guidelines for the treatment, which are evidence-based I think इतना ज़्यादा हर तरफ से information आ रही है, and I think as scientists we have to follow some guidelines. I think I find कि NIH की जो recently released guidelines हैं, they are online, and I find them very useful. So what do you suggest? This is my comment also, and as a question as well. कि कौन सी guidelines follow करें?
I think what I have and please all of you are knowledgeable enough in dealing with the on ground. So what my understanding is that they are not asking us not to use that, but they are giving us a very specific guideline. They are telling us that you can use it. They are not recommending it, but you use it in a steady state. If you are doing a trial, then you can use it so that people can benefit with your experience. Don't use it just because somebody is saying that use it, or we think that it might have some positive impact on one or other state of the disease process. So let's move on. We have multiple other questions. Somebody asked, I think they're asking from the Pakistan about there's a patient came to the OPD and later on was found to be positive for COVID, and the doctor was asking, should we close our OPDs? What should we do? What not? Professor Shamsa? Professor Shamsa, yes. For the opening or closing the OPDs and protection of the healthcare providers, how to deal with these things.
देखिए हमारे जो मेरे अपने हॉस्पिटल में आई कैन गिव यू एग्जांपल, हमारा तो ओपीडी बंद ही नहीं हुआ था बिकॉज यहाँ पे पब्लिक प्रेशर इतना ज्यादा होता है, गवर्नमेंट भी कुछ चीजें करती है, कॉस्मेटिक के ओपीडी आप चलाए रखें। ओपीडी में वैसे तो लोगों को लॉकडाउन की वजह से काफी रश कम है, इवन इन प्राइवेट हॉस्पिटल्स एज वेल, बट व्हाट वी आर डूइंग, हम अपने पूरी प्रिकॉशंस जो डॉक्टर्स हैं फॉर टू सेव देम, टू कीप देम सेफ फ्रॉम कोरोना, क्योंकि लोग आपको पता हर तरह के आ रहे हैं। तो मेरी तो यही है कि जब ओपीडी बंद नहीं होना और तो एटलीस्ट हेल्थ केयर वर्कर्स शुड ऑब्जर्व ऑल द प्रोटेक्शंस। और सेकेंडली जो इवन प्राइवेट हॉस्पिटल्स में तो जो पेशेंट्स भी आ रहे हैं, दे आल्सो ऑब्जर्व ऑल द प्रिकॉशंस, वो सैनिटाइज भी कर रहे हैं, अपने मास्क भी पहन रहे हैं। तो आप 100% ओपीडी बंद तो नहीं कर सकते, थोड़ा बहुत तो आपको चलाना।
जी I have a quick comment. Being I studied in Rawalpindi Medical College, which is a government college. I totally understand. अभी तो काफी अर्सा इधर हो गया, लेकिन we have gone through the same system. I know how the OPDs are. लेकिन it's a very difficult situation आप लोगों के लिए if government mandated, हमारा government mandated elective procedures are off and everything is on tele. If there is no government mandated tele, एक चीज जो मेरे ख्याल में की जा सकती है, I may be wrong क्योंकि आप लोग सिचुएशन में है कि other than the patient load अगर कम है तो kind of follow the 3 feet or 6 feet rule and everybody can wear N95 with the patient interaction. Simple things might help. Just a thought that I had, I thought I'll share.
Yeah, I have a colleague in Karachi and she is involved in primary care setting. And she sent me a picture that outside of their clinic, they had open area, a ground kind of thing, and they put some kind of chalk marking, a circular thing, and patients are sitting 6 feet apart from that. I was so surprised and happily surprised to see this kind of practice over there. So, they can improvise and they can do. Yes, Dr. Shamsa.
हाँ जी, ये इम्प्रोवाइज तो आप कर सकते हैं इन सर्टेन सेटिंग्स, लेकिन जहां आप जैसे डॉक्टर फवाद ने अभी कहा फ्रॉम रावलपिंडी के एक्सपीरियंस से, या आप रावलपिंडी, लाहौर, कराची के अलावा भी पाकिस्तान है जो कि बहुत बड़ा है और जिसमें THQ और DHQ में अभी भी 200-200, 300-300 पेशेंट की ओपीडी हो रही है। यस्टरडे डॉक्टर वाज टेलिंग मी कि उसने पेशेंट का स्टूल अपने जो एंट्री थी दरवाजे में 6 फीट दूर रखवाया, तो पेशेंट उठा के स्टूल उसके पास लेके आके बैठ गया। The next day what she did, उसने उसको रस्सी से बंधवा दिया कि वहां से कोई स्टूल ना उठाए ताकि पेशेंट वहां बैठा रहे और उससे वो दूर रहे। तो उसने कहती है कि मैंने कहा जी नेक्स्ट पेशेंट, तो कहती पेशेंट नहीं नजर आ रहा था। मैंने कहा पेशेंट किधर गया, तो पता चला पेशेंट नीचे बैठ के उसकी रस्सियां खोल के स्टूल उठा के उधर लेके आ रहा था। So we encountered different because the more the concept is आप जितने नजदीक अपने डॉक्टर के पास होंगे उतना ही बेहतर वो आपकी बात सुनेगा। So dynamics are very very different here और so हमने तो यही instructions दी हुई हैं कि जो डॉक्टर्स वहाँ बैठे हैं वो फुल प्रोटेक्शन लेके बैठे हैं। हमारी अपने जो मेरे अपने ओपीडी में मेरी यूनिट की लड़कियां डॉक्टर्स हैं उनको हमने फुल प्रोटेक्शन दी हुई है, विच मीन्स वो अपना जो किट है वो भी पहन रही हैं, प्लस दे वियर देयर मास्क एंड जो ग्लव्स हैं तो एंड शू कवर्स, हेड कवर, सब कुछ हम पहना के बिठा देते हैं because you never know that you are encountering corona or not.
Exactly.
Thank you very much. So few more questions, and we are already over time, but I'm trying to ask as much as possible. So there is a question about is there any study anybody knows about the stress level of asymptomatic COVID patient? Any available data who are in quarantine, somebody who is positive but not too symptomatic in quarantine? Is any kind of study available to see what are the stress level and how the people are dealing with that?
Stress level?
Mm-hmm. Psychological stress related to diagnosed COVID and not too symptomatic, staying home.
Yeah, interesting question. I think if there was a psychiatrist in the panel or attendees, they can probably answer.
Anybody who want to chime in, raise your hand. If not, then we'll try to find out from our psychiatric and probably answer in the next session. Somebody else asked about any kind of protocol anybody knows about how to do the home quarantine. Any kind of video available on the net. Dr. Morton, you have a lot of resources. I see you sharing a lot of things to us. Dr. Morton?
I haven't come across,
You didn't come across
I've not come across any kind of special video to show how to do quarantine, but I know there are a lot of things on YouTube that are going around telling people how they should be separating their food and how they should be having one bathroom to themselves and making sure that all their belongings are kept separate from the rest of the family members.
Okay. Good. Thank you. Yeah, go ahead.
I have. Thank you so much. Some internet problem and I had to reconnect again. We have a home care program. I shared this with Dr. Kabani, and she said she's going to review it. A lot of consultants here and even public people, educated, they've reviewed that and they find it very informative. As I see, we are going to peak, and I think people will have to, self-quarantine.
Okay, thank you. One more question about any kind of relationship we know of this COVID-19 with that of the climate. And I think the questioner probably wanted to know whether the change in the weather, hot weather, has any kind of known impact in terms of its effect, its vulnerability and effectiveness to produce disease process. Fawad?
So we know that hot weather itself, virus cannot live long. So they usually are not able, from the prior influenza and other viruses studies. So this virus is acting so much or in many ways different from other influenza viruses. So we assume that hot weather should kill it, but we don't know. That's what my understanding is. I think any ID expert can chime in here.
Dr. Bushra? Dr. Bushra, do you have any comment on this?
Yeah. So we are actually seeing a steady increase in number of cases, but this has not been a logarithmic increase. This has been a steady increase. So I think we are moving towards our peak. So we don't know actually what the impact of this warm weather is going to have on spread of infection, because I personally believe that had we hit the peak during winter months, we would have encountered many more patients. So we are yet to see a logarithmic increase. There has been a steady increase, and that has to do with the availability of testing as well. So we are seeing an increased number of cases at all centers, but I don't think the capacity is overwhelmed, and the weather is really hot. So we just need to observe what goes on in the coming weeks.
Okay, thank you. So 2 or 3 more questions, and I'm quickly want to get some answer. Dr. Bushra, there is another question about how to prevent if somebody develop upper respiratory tract infection, to convert it, to prevent it from going into doing pneumonia. You know, like somebody, you know that everything starts from the upper airway, goes down to the lungs. Is there any kind of magic we have? Any kind of understanding? There are a lot of YouTube videos and other things stressing and promoting different kind of homemade remedies and grandma recipes. Any comment on that?
Nobody knows, and especially because none of the therapeutic modalities are being recommended for mild cases. So we have no idea what will work in a mild infection and what will not work. So, and then a huge proportion of people remain asymptomatic. So we don't even know what factors determine who will remain asymptomatic or go on to develop symptoms. And then obviously the known factors which are associated with severe disease are increasing age and presence of comorbidities. So somebody who already has a chest condition, diabetes, hypertension, and so on and so forth has a high likelihood. And there are no studies showing that there is any therapeutic agent or non-therapeutic agent which would block progression from mild to severe disease. So what I tell my patients is just use which makes you comfortable, and that's about.
If we have enough data in a year, that might be the way to go. But you know, we don't have much data about that at this point about remdesivir.
Very good point, because steroid has this kind of issue of virus shedding and increasing effectiveness. That's the reason all the societies, including SCCM, recommending not to use in non-ARDS patient even if you have. Yes, Professor Shamsha, you have some comment?
Question था, I was wondering yesterday, once here in Pakistan burial के लिए बहुत ही special precautions दी जाती हैं. Once a patient has died, I want to understand कि अब वो कैसे spread करेगा infection, जब आपने उसको spray भी कर दिया, सारा कुछ कर दिया. So someone would enlighten me, इसका क्या है concept?
I think it's a very important and very good question. Anybody from my panel want to take? Dr. Bushra, being an ID, Pakistan.
थोड़ा सा मसला ये हुआ है कि NIH की guidelines different थी and Sindh Healthcare Commission ने अपनी different बनाई है. So there are different groups which have come up with their own specific guidelines, and they are erring towards being very overcautious. दूसरी चीज ये कि हम सोचते नहीं है. For instance, people report taking X-rays of a dead body and then saying कि इसमें infiltrates हैं. इसी तरीके से actually बिल्कुल सही कह रही हैं प्रोफेसर साहिबा कि ट्रांसमिशन तो रेस्पिरेटरी रूट के थ्रू है या हाथों से गुस्ल के बाद तो बॉडी it will be very difficult to transmit infection. तो थोड़ा सा thought process डाल के, and all these policies and procedures should be reviewed and revised by educated panels जो सोच समझ के ऐसी चीजें करें जो practical हो, doable हो, and risk भी minimize करें. So I agree with her completely. But
So
there is a connection between.
Can I give a suggestion, a comment? Can we in Pakistan? We all know from our science what exactly is going to spread the disease and whatnot. Can you guys from there talk to the health educator and put some kind of campaign on the TV, some kind of news channel, interviews, guiding the people? I think people are very confused. So you guys can communicate to each other and see what we can do, because this is a very important issue.
इसलिए इसलिए डॉक्टर कलीम के आप टीवी पे देखते हैं उनका बरियल इतने वो एक जेम्स बॉन्ड या जिस तरह शर्लक होम्स की तरह उनका बरियल किया जाता है। सबसे पहले तो बॉडी नहीं देते, ठीक है, वो रिलेटिव पहले गम में होते हैं और रो के और बिलक बिलक के पागल हो जाते हैं। फिर वो एक स्पेशल एक गोरकन बुलाया जाता है जो कि वो भी बड़ा रिलक्टेंट होता है, फिर उसको रस्सों से बांध के उसमें उतारते हैं। सो दैट इज वेरी हॉरिफाइंग फॉर द फैमिली। तो मैं बड़ा सोच रही थी कि अब उसका रेस्पिरेटरी ट्रैक तो बंद हो गया, हाथ वो हिला नहीं रही बॉडी, आपने उसको लपेट भी दिया, एक सील भी कर दिया, फिर आपने उसको एक कॉफन में भी डाल दिया, बॉक्स में भी डाल दिया, तो हाउ इन्फेक्शन कैन ट्रांसमिट नाउ? इसका कोई मतलब लॉजिक होगा? लोगों ने जो इतनी इसके लिए की है तो प्रोबेबली दे मस्ट बी हैविंग सम अंडरलाइंग कॉन्सेप्ट और मैकेनिज्म के स्टिल इट इज इन्फेक्शियस।
I think it's all fear. I think it's all fear. I think we need to. This disease has many dimensions, and I think one of the factors, the fear beyond proportion. I think is kind of very sad. So I think you guys who are on the ground in Pakistan, Doctor, we have multiple panelists and others who have resources and communication with the healthcare, advisors in Pakistan, and try to do some kind of public service announcement to make sure after getting all the data so that people, don't do these kind of things. So I think we are much over time. The last question which I'm going to ask Fawad is somebody asked me about the role of ECMO and inhaled nitrous oxide in critically ill patient in COVID.
So I think I replied in privately as well, but that's good you asked. I'll just mention it again. So the role of INO from before COVID as well, we know that the two things that affect mortality, improve mortality in ARDS is low tidal ventilation, low tidal volume ventilation, which is around 6 ml per kg, and proning. We have INO, which improves oxygenation. We have neuromuscular blockage, which improves and helps oxygenation and helps proning. They don't have much effect on mortality. Neuromuscular blockage had one study in 2011 that showed mortality, but lately it hasn't shown. So bottom line, we will recommend to use initially low tidal volume ventilation, PEEP strategy per ARDS net protocol, paralysis and proning early within 24 hours if possible. And then if they are not getting better with these techniques, then consider trying INO for improving oxygenation and improving overall, getting to your numbers and low FiO2 and towards extubation, you can try INO. Now, ECMO role comes number 5. So if despite all that, they are worsening, then ECMO. What we do is after 24 to 48 hours, if things are not moving, and if their PF ratio is under 100, we involve our ECMO team so they are ready. So I would say the studies regarding ECMO showed the outcome is better if it is tried within the first few days. So that is also important to consider, that if you want to do ECMO, get it done within the first 4 days or so. So number comes last, but try it early if things are not working with the PF ratio below 100.
Thank you very much, and I appreciate all my panelists, Fawad, and all the attendees. At last, ask panelists to have any last comment before we close it. Dr. Muhammad Asim, anything?
Thanks, Fawad. Excellent talk. Just a quick thing which just crossed my mind. Both of you guys are seeing COVID patients in ICUs. There's a lot of paranoia about in Pakistan, about in the hospital, as mentioned before by all the professors Saibans here as well. You see, what happens is patients are doctors, junior doctors, everybody's so paranoid that they're seeing a COVID patient. What the hell is going to happen to them? What if they take it home? I just wonder, you two seeing ICU patients where there's a lot of risk of you taking it home, because there is a lot of aerosol generating procedures, intubated, blah, blah, blah. Are you guys taking any specific precautions apart from the usual ones which you will do, doning, doping, all of that? Are you guys to protect your families? Are you guys doing anything different? It's just to highlight something for the audience here, because I feel that every time there is a COVID patient in our hospital, everybody gets so paranoid. As you quite rightly said, it is a disease which is teaching us a lot of things, but we need to get used to it, because I feel this is going to stay and we need to change the way we practice and how we think about it. So just thoughts, sorry, I'm taking too much of your time, but I just wondered if you can shed some light on it.
I think you have a wonderful question, and I think I will pass it to Dr. Moten, and she could also have a final comment and also answer this thing if you could. And Fawad can also join in.
Thank you so much for your question. I understand everybody's worried. We all are worried about getting infected and bringing the infection home. Generally, we are taught that we must clean our surface areas that we have touched at work, the station that we are using, to make sure we clean it before we are changing our gloves and everything. And after that, as we leave, we use the sanitizers and make sure that we leave our face mask at a certain place so that we don't take the same face mask home. When we get home, we always tend to go ahead and take care of our outer clothing in the garage so that we don't bring it inside the house. More often than not, we are being encouraged to take a shower before we go ahead and do any of the housework.
Absolutely, totally agree. Totally agree. This is the way we do. And also, what I'm doing is I'm instead of my usual clothing nowadays, I use scrub, and I take off my scrub in the hospital and use my other scrub back home. So basically, your concern is absolutely right, that we are the only people, our household, our family, loved ones is going to get in contact with us because they are quarantined, or not quarantined, they are in the home, because of the lockdown. But we are the only one who are getting exposed. So taking extra precaution, although it is not recommended by any society to take shower or thing like that, but I think the common sense approach, and we are doing it. What, anything to add?
I agree. Yeah, I agree. I do the same. I change the scrubs into hospital scrubs, change it back before coming, and rest of whatever you and Dr. Moten said. Exactly.
Dr. Shamsa, any last comment?
जी मैंने सारी ये डिस्कशन सुनी है. स्टिल जब आप कोविड का नाम, मुझे फोन आता है जी एक पेशेंट कोविड पॉजिटिव आ गया, सिटिंग एट होम, आई एम हॉरिफाइड. और आप जो भी कर लें, वी आर टेकिंग ऑल द प्रिकॉशंस. एंड ऑफ द डे दुआएं सबसे ज्यादा करें कि अल्लाह आपको बचा ले, और कुछ नहीं.
I mean, this is $1 million thing. Being a believer, how the disease process is affecting 81% nothing, mild, and then 5%, which we can do a lot of things, and it's more than 50% mortality. And we always ignore this very important factor, which is our belief system, that Allah is in charge. We do our best in terms of take care of ourselves. Dr. Shahid Rafiq, anything at the last? I'm getting too much over time. I'm sorry.
Gee, no problem. Thank you for another excellent Fawad, very nice talk, and Kaleem, as usual, very good moderation. I wanted to thank everybody, and just for the Ramadan timing, we are stopping this nightly. So it is our nightly, but in Pakistan, it's a morning session. The last one will be Pakistan morning Friday. So Thursday night here in United States will be our last daily webinar. During Ramadan, we are only going to have it on Saturday and Sunday. And the timing will be 5 p.m., 5 in the evening in Pakistan. So that by 6 o'clock, 6:15, everybody's done. And I think that you will have time to prepare for iftar and all that. We had a survey, and this is the best timing most people have told us. Here this will be 8 p.m. Eastern Standard Time. Sorry, 8 a.m. in the morning Eastern Standard Time, Saturday and Sunday, which will be 5 p.m. in the evening in Pakistan. So we'll hope that all of you will keep coming back on 5 p.m. Saturday and Sunday during Ramadan, and then we'll see after that what timing will suit better.
Okay, thank you. Dr. Nushat, any last comment?
No, I'm good with what everybody has said, and just keep it up. Thank you, guys.
Thank you. Dr. Bushra?
No, thank you. I think we had a great discussion. Thank you.
Thank you very much, all of you. Again, thanks for participating. And inshallah, with this effort, we try to help our colleagues, ourselves, in terms of taking care of this very serious and unknown disease process, the best of our capacity, and with the help of Allah, we'll be successful, inshallah. Thank you very much again.
Thank you. Allah Hafiz.